Welcome, everybody. Everyone like to take a seat? Just take a seat anywhere there is a seat. That would be great. To begin, I'd just like to acknowledge the traditional custodians of the land on which we're gathered, the Yagara people, the Waka Waka people, the Turrbal people, the Gubi Gubi people, and the Ninji people as well, and their elders past and present and emerging, and Indigenous people here today. Our focus is on the older people, and it's lovely to have the traditions of Indigenous culture in terms of respect for older people as a model that we can all look to. Welcome to you all. You've been given flags because we've got this whole Switzerland thing happening here. And the idea of today was really just to recognise who is in your bit of the sector on the one hand, but also to encourage mingling between the bits of the sectors at the same time. Throughout the session, throughout the session, you may hear things that inspire you, and you'll find little bits of paper, little cards, or don't inspire you. Either way, you can have it either way, actually. So if you want to write things on it, that would be great, and we'll focus on that a bit later. And we will put them up on a board like that. There's a washing line over there for your thoughts, and they'll be displayed in a public place, so any expletives will be deleted. Central to the Health Alliance activities is a focus on patients, consumers, the people we look after. And so I want to have a special welcome here for our consumers who are here. We will meet some of them later, but I would particularly like to welcome the people from Kapira Sanctuary Village who have joined us as well, and who are sitting here with Amy and Laurel, who's sitting in the front. Now, to begin, can I now welcome Ageing Revolution, Simon and Leonie from the Ageing Revolution.
We're over here if anyone's looking. We didn't know where to stand. It's like, I don't want to stand in the middle.
There.
It's too intimidating.
Simon and Leonie, could you irreversibly change our perceptions, please?
I hope so. So I'm Leonie.
I'm Simon. And about just under 3 years ago, we founded a company called the Ageing Revolution. So I used to run Seniors Car for New South Wales. Leonie ran it for Queensland. We met, fell in love, created a business, usual story. And we thought we wanted to look at the ageing system differently, from a positive perspective, from a consumer perspective, and what it means to age. So we thought, how do we do that? So we actually self-funded a 5-month road trip around Australia, covered about 16,000 kilometres as far north as Cairns, Darwin, Uluru, to ask what it was like to age in place. What's it like to age in your community, rural or regional? Some of the anecdotes, some of the commonalities, some of the difficulties. And we've come back and used all those learnings to try and inform companies and governments on how to treat ageing in a positive light and in a better way. We've actually got some cartoons on the board over there if you want to have a look later, or come and talk to me afterwards about some of the interesting and fun things, or prejudices people actually found by growing older. And on that note, I would just like to start off with a small exercise. So if you could turn to the person next to you, left or right, just introduce yourself, tell them your name, and tell them how old you are.
Okay. So has everybody had a chance to tell everybody how old they are and introduce themselves? And I'm just wondering if how did that feel to do that? Does anybody want to let us know, how did that feel to actually turn to someone and say, this is my name and this is how old I am?
I've got a mic.
It was interesting. I had to think what year it was to work out how old I was. So that was
2018. Anybody else?
We played the guess.
Oh, and how did that go?
It was fun.
Okay. Younger, older? Okay. It's always the way to go.
I hate telling people my age because when I say I'm old, they say, what, about late 60s, early 70s? I'm actually nearly 80.
Well done. So we'll try something a little bit easier perhaps. So this time, if you could turn to your neighbours and if you could tell them your passion and what gets you out of bed in the morning. What is it? Take a second to do that.
And be polite. All right. Sorry, we've only got a limited time, so we've got to keep hurrying up. So now, how did that feel? I bet that was a lot easier. One of the things we learned, I feel like I should just keep twisting. One of the things we learned on the road trip was how diverse people are. And my actual background is genetics, and kind of one of the things I learned, that the longer something's around, often the more diverse it gets. So one of the questions we pose, and it's worth thinking about for the rest of the day, is why all of a sudden do organisations and companies and government treat a cohort that's over 60 just exactly the same, when actually there's more diversity probably in this room than in sort of many, many other rooms. And I think you probably found that because of talking to you about your passions.
So now that you know a little bit more about each other, we're going to change the scene altogether. So is there anybody here who's over 80? All right. So you're all going to join Eric in becoming 87. You're all now 87. So what that means for you, so you've all been given a new age, is that you were born in the year 1931. Your contemporaries are people like Rita Moreno, Mikhail Gorbachev, Rupert Murdoch. You were 38 when the moon landing occurred. You were 44 when the Vietnam War ended. You were 58 when the Berlin Wall came down, and 74 when YouTube posted its first videos. Now, you're in the last years of your life, and I want you to close your eyes just for a moment and imagine where you are. Where is your final home going to be? What do you want to have around you in your last home? How do you want to live those last years of your life? And who do you want to have there with you? Just so you remember all the questions that I've just asked, they're up on the PowerPoint. So if you could just take a little moment to think about that, and feel free to discuss that as well. So where's your last home? What do you want with you? How do you want to live those last years? And who do you want there with you?
I'm taking the silence that everyone's thinking. Okay, so how hard or how easy was that? How many of you actually thought about that before? Stick your hand up if you thought about that before. It's not a whole bunch. Would anyone care to share where they want to end up? See if I want to live with them?
I'll have a go. Like Thea over there, I also live in Capera Sanctuary, and that's where I'd like to live till I die. As would the vast majority of the people who live there. Now, not everyone goes for retirement living, but it's an interesting concept because we have just over 300 people there, and probably our most frequent health service is the Queensland Ambulance. And there's a lot of thoughts you could put behind that of how you get to need the Queensland Ambulance. I've never had to use it, and I've been there 8 years with my wife.
Why do you like it?
I like it because it allows us to interact with a lot of people of the same age group and understand where we're all going. You can't do it if you live in suburbia, but you can if you decide to live in a group of people, a community of people. And you find that the other side of it is you've got 300 odd people with a wide experience of life. Different...
And many stories, I imagine.
And many stories, but it's the wisdom that comes with old age.
Awesome. Thank you very much.
Bernie forgot to tell us that it's a beautiful spot and very convenient for shops and transport.
That's important. Did anybody think of their last home as something different to that?
Phil. Oh, shit. I'm on. Yeah, I know. My last home, I basically had a thought that I've lived my life like at full revs for 87 years. My last home is going to be by the beach or near a forest by myself or with my husband. And the things I want to have with me is my library, the books, because my books have been with me all my life and they stimulate me. I will finally get to finish Finnegan's Wake somehow, but I want to have some quiet time and some solitude after having been so busy for so long. To be alone and quiet would be what I really want.
It sounds like something you've thought about before. Okay. Had anybody not thought about it before and want to share?
Well, I think that I probably love to pretend that I'm not ageing at all and always try to live young. And so, yeah, I haven't really planned where my last home will be.
So did those questions help you to start that process a little bit? Yeah.
Great.
So just to give you a little bit of an idea of some of the work that we're doing as the Ageing Revolution, I think, Simon, you were going to talk to us a bit about the different things that we're doing to challenge people's perceptions of ageing.
We, one of our main jobs is to challenge, like Leonie said, the perception of ageing. We do lots of talks about ageism, especially in the creative industries, because apparently if you get over 40, you're not creative anymore. I'm sure a lot of you will disagree with that one. We're also working in sort of the virtual reality space, where you can actually become someone different. And that's not just ageing, that's also disability. And we're also we're trying to find how to use technology to actually improve the lives of ageing Australians, whether that be a carer and improving the lives of carers through meeting other carers. And I saw the plenary, you talk about artificial intelligence and the role that can play without removing the human element. I think that's key. We can't go too far down technology and remove the human element. So if you want to know more about what the Ageing Revolution is doing, we'll be over there at the end of this, and you can talk to Leonie or myself. I hope you've enjoyed that little warm-up. I'll hand you over to the next speaker. Thank you.
Thanks, Simon and Leonie. Just on that technology thing, can I just make a suggestion, Simon, that you look at, when you go on a website because you've forgotten your password, and then you go to put your age in, and so, 8th April, and then it says 2018, and you go, 2000, 1990, 1980. Could somebody fix that? Thanks. Yeah, thanks very much for that. Oh, could someone answer that phone, for God's sake?
Oh, sorry, that's my phone. Excuse me. Nurse Navigator for Radar.
Hi, it's Kylie.
Ah, Doctor, how are you doing? How can I help?
Look, Karen, can you get Radar on the move? I'm just here at the nursing home visiting Joan again. She's got a really bad upper respiratory tract infection. I've started some antibiotics and some oxygen therapy, but we're just a bit concerned that it's beyond what we can manage here. And rightly, her daughter is quite concerned about how things are going. So we need your help.
Oh, yeah, we can help. That's what Radar's here for.
Wow. Oh, that was helpful, wasn't it? Okay. This issue, revolutions of this nature take leadership. And so it's my pleasure now to introduce some of the existing leaders who have brought us to where we are today. And I'm just trying to find Liz. Liz, introducing Liz Whiting. And Liz is Executive Director of Clinical Services at Metro North HHS, but more meaningful for some of us, a geriatrician and general physician at the Prince Charles Hospital.
Sitting strategically beside the microphone. So thanks everybody. So what a great session this is. So I'm here just to talk a little bit about what we've been doing. I've been given 7 minutes and no more to talk about what Metro North has been doing in the space of caring for older people. So I've got a few slides. So last year I was invited along to talk about the Year of the Frail Older Person for Metro North. And we talked about how we had really recognised how our system was not set up to provide the sort of care that achieved optimal outcomes for older people, and in particular the most vulnerable group who are frail. And so we spent the year trying to create that knowledge and that burning platform around how we might do things differently. And we engaged with many, many clinicians across the whole health service, and we were really very optimistic and I suppose surprised in some way that so many people were interested in actually doing better in the field of practice that they were in. So there were a lot of initiatives over the year, and we recognised at the end of the year that we had started a lot of fires, but we had a long way to go. And so what we accepted was that we would actually be in for the long game, not just 1 year for the frail older person. Acknowledging that, we have embarked on a multi-year strategy. So during the Year of the Frail Older Person, we did a 5-year plan, which is really the short and medium term for us, and we did this in collaboration with the PHN about what care for older people will look like in Metro North over the next 5 years. And we also developed a palliative care strategy. So we're now looking forward to the future and starting to embark on the implementation of those various plans. So you just had a little taste just before of what introducing Radar. So over the last few years we've tried to start looking beyond the hospital walls and started to acknowledge that there's a big gap between primary care, community care and the hospital. And this big gap, neither primary care nor the hospitals are very good at actually responding quickly to someone who's deteriorating in their home or in their residential facility. And so what we recognise is that people want to stay home and stay well, that being in hospital introduces all sorts of risks and, as Don suggested before, potentially poor outcomes. So we're now starting to look outside of the walls of the hospital, and we've introduced the concept of Radar. And we knew that across Metro North, where we have 5 hospitals and a big community service, that we are really quite fragmented. We had little pockets of innovation that were happening. So Redcliffe had developed their outreach program to residential facilities. Prince Charles had just embarked on it in collaboration with the PHN. And really what we needed to do was to build on that program. And we've introduced the concept of Radar. So Radar is where we're going to centrally coordinate through our patch an integrated responsive team that's beyond the hospital walls, with the purpose of responding quickly and hopefully supporting someone to get well more quickly in their own home or in a residential facility. So the initial phase will be to build on the Redcliffe and Prince Charles model and to have a Metro North-wide Radar where from all of the hospitals we will coordinate through Patch a response to the residential facilities when someone is deteriorating and they're in urgent need of support. Hopefully to keep someone in the residential facility and support them through our hospital and the nursing home to recover, or if they come to hospital, to be able to respond quickly and appropriately and to be able to return back to the residential facility as quickly as possible. We also had started with Grace, which was a way of connecting GPs to the hospitals without having to send someone up to the emergency department, whether that's through an alternative pathway or phone advice with an on-call physician. So we're going to actually systematise that as well, and through the Patch we'll hopefully coordinate a response when a GP wants to pick up a phone and talk to someone rather than send someone up in an ambulance to the emergency department. As we progress, we have plans to build on our community palliative care service and the responsiveness of that, and then also the big gap that we have around older person mental health and behaviours of concern related to cognitive impairment, where again we often find people ending up in the emergency department where we're not set up to respond to those issues, and in a hospital ward where again we're not necessarily well set up to respond. So over time we're hoping that we will have a well coordinated, responsive, comprehensive service that will keep people in their own home and as well as possible. Building on the work in both in the hospital as well as outside of the walls of the hospital, so we've ignited all these fires in the year of the frail elder person, and we have our plans that will take us over the next few years, but we decided to set an aspirational goal. We really wanted to be excellent in what we do, and so we're working on this concept of care of the Older Person Centre of Healthcare Excellence, which we're calling Co-op Excel. And so you'll see on that MN32 plan, which is the aspirations for the health service around robotics and genomics and 3D printing and all this kind of stuff, Co-op Excel features there. So by 2024, we want to be nationally recognised as a centre of excellence for healthcare for older people. And these are the domains you can see there in the diagram in the middle. So we really want to have a patient focus. We really want to deliver person-centred care. And so that's the links that we've developed with Capera community will be really helpful, but as we progress we really want to mature into a space where we actually are delivering care and responsive to what matters to a person as opposed to what we believe is a priority. We're very fortunate in terms of leadership to have leadership right from the highest level in the health services, and that's our CEO who chairs the committee for older people, and we have committees at each of the hospitals, and we'll join that up and we'll be able to garner that leadership, but also to provide leadership beyond Metro North and hopefully influence the state and the country in terms of what excellent care looks like for older people. Can't even read this now. What is it? Innovation and learning. So we want to be leaders in research and education. So we want people to know Metro North as a place to come to build skills. In terms of efficiency, we know that a lot of the care we provide in hospitals and beyond hospitals doesn't necessarily deliver value for the health dollar. We really want to focus on what's important. We want to eliminate waste, and we want to listen to patients to guide us in what we do. In terms of our internal business, we want to make sure that the hospital is set up to deliver care in the way that is best organised to get the best outcomes. And so with our skills, with our infrastructure, with our leadership and our policies and procedures, it will be orientated to deliver on that. So we do have a very aspirational goal.
Thanks very much, Liz. Yes, thanks very much. We can't accuse you of not hugging the limelight. So I'd now like to, there's Michelle. Introduce Michelle Smith. Michelle is the Executive Manager of Aged and Community Care for Brisbane North PHN, but she's a lot more than that. Michelle, over to you.
Thanks, Don. I'm feeling a bit starstruck. So why am I talking about dementia? Why pick that as a topic? I'm not claiming to be an expert on dementia at all. I'm a registered nurse, and my role in the PHN is about trying to improve the health of people in our community, particularly those that are vulnerable. But I am female, I'm middle-aged, have to say it. I have hypertension, I've had significant periods of stress in my life, and this makes me a high risk for dementia. Dementia is the leading cause of death for women in Australia at the moment, and the third cause of death overall. So it's a significant issue. And could I ask, please, if you would raise your hand if you either have dementia or if you are concerned about developing dementia? Yeah, so I'm not alone. Yep. Dementia has a physical, psychological, social and economic impact, not only on people with dementia, but also on their carers, families and society at large. So just a few statistics. We know that at the moment there are around 413,000 people in Australia diagnosed with dementia, and by the mid-century that's going to rise to about 1.1 million. It is a big problem. We've got 3 in 10 people over 85 with a diagnosis of dementia, and we're all getting older. It's actually not a single specific disease. It's an umbrella term for a syndrome that's associated with more than 100 different diseases. And it's characterised not only by memory loss, which we normally associate, but impairment of brain function that includes language, memory, perception, personality and cognitive skills. And it's one of the major causes of disability and dependency among older people worldwide. Economically, the current cost of dementia is estimated at about 14.5 billion, and by mid-century, once again, it'll be about 37 billion. So it is a big problem. I was lucky enough to go to an international dementia conference in Sydney recently, and just wanted to share a couple of things from that which I thought were really important for what we can do here in our local area. So the first is around what we think about people with dementia and our expectations of them. And secondly, it's about dementia as a chronic disease. So beliefs and expectations. One of the UK researchers presented on a dementia study in biomarkers to inform biomedical testing for earlier diagnosis, and they had expected volunteers would be difficult to find because part of the research methodology required that people would need to undergo a lumbar puncture, and so for many of you know that's a risky procedure. But they were overwhelmed by the number of volunteers and ended up with a wait list. So that's an indicator of the level of community concern about dementia. And what is it that comes to mind when we think about dementia? It's been described as a malignant tragedy, and the words associated are often of loss, of someone being missing, gone, an empty shell, and it's a feared and stigmatised diagnosis. And perhaps that's a bit similar to how cancer once was, before we had effective treatments and better prognoses. When we think about the services and supports available for people with dementia, are they disabling or enabling? And do we define people by their disease or consider their right to agency in every way possible? Standards around human rights and disability rights have been brought about by declared values, beliefs and commitment to change. And it's no longer okay to lock people with mental illness or disabilities away in asylums or institutions, as occurred in the past. So we need to make sure that we're removing barriers to an active life for people with dementia, helping to add life to days and not just days to life. We also need to address issues of consumer-directed care for those who have cognitive impairment. And as you know, there's a big shift in our systems at the moment to more consumer-directed care. There's a global groundswell happening that's advocating changes to policy and awareness and care practices, and this is heavily influenced by consumers themselves. We have Australians like Kate Swaffer and John Quinn making great achievements in changing the conversation on dementia to be more capacity focused rather than deficit focused, telling us that we need to have more room for positives and how to live well with dementia. Their aim is to die with early onset dementia rather than from dementia itself. So dementia is a chronic disease. Although dementia mainly affects older people, it's not a normal part of ageing. And if we start thinking of dementia as a midlife disease rather than mainly a disease of older people, that kind of changes the dynamic. Most chronic disease starts in the 40s and 50s, and Alzheimer's disease, which accounts for about 60 to 70% of people with dementia, is probably the same. However, someone with a diagnosis in that age group would be called early onset. So early diagnosis is key for prevention, and we have drugs that can treat the amyloid and tau in the early stages, but later stages of the disease, there's multiple pathologies and it's really very hard to treat. In the early stages of the disease, there won't be symptoms, so we need risk profiling and prevention, assessment and biomarkers for earliest possible diagnosis. And as with other chronic diseases, as we heard from Stefan this morning, lifestyle factors determine both the risk of developing the disease and how quickly it progresses. So there's no shortage of evidence about that, as we've heard. So progress is being made globally on research, and rather than an evidence gap, perhaps we've got an implementation gap in prevention. So how do we create a better system locally from all of that? There are international and national strategies, which I won't go into, that do detail, the different areas of prevention through to end-of-life care for people with dementia. There's the federal government has recently announced funding in technology to support dementia. But what we need is a system approach, collaboration, working together about what it is that we can implement ourselves. Our 5-year strategy for older people prioritises dementia as an area of work, and so what we'd like to do over the next 12 months is work with all of you on how we can improve our response. Some of those things would include the special dementia care units, which will help to keep people out of hospital if they're experiencing severe behaviours. Workforce, we need a better trained and educated health and care staff, and we need change champions across organisations to transform practice. And we're hoping that that's many of the people in this room today, so I look forward to working with you all. Thank you.
Thanks very much. I just want to acknowledge both Michelle and Elizabeth for the leadership they have shown and continue to show that's brought us actually a long way to where we are today. So thank you very much. Our third speaker in this spot has a lot to answer for, actually. So if anyone's got one of these or something similar of a different colour, could they pick it up? Could you pick up your flag? Anyone with a flag? And wave it? That's cool. Yeah, and this guy's responsible. Can I now introduce Ken Whelan, who used to be the CEO at Metro North HHS. He was responsible for this whole Switzerland idea, you see. So that's why I'm blaming the flags on him. Ken, over to you.
Thank you. I think I might move away. As I get older and look up into the sky and see a bright light, it scares the hell out of me.
Let's go in the middle if you like.
Thanks, Don. I'm going to be a little bit provocative in the 6 minutes, 45 seconds I have remaining. Don's right. When I was here at Metro North, actually I moved from there so I wouldn't have back, and I was coming in here and it's even worse, actually. Two things happened for me as Chief Executive at Metro North at the time. One was Liz, and people started to keep talking about the older person with frailty and the damage that we were potentially doing within the hospital system. And then we had a guy from the UK come out, have a look, and gave us a major serve, actually. And it made me feel really bad in terms of the harm that we were doing these folk in our system. So from there we got involved, and the rest is history, and people now have taken it to a level far beyond where I had it. But one of the things I've done in the last 12 months is work in a number of systems, and I've carried on the passion of how we care for the older person that actually has some physical issues going for them. I've done some work in New South Wales and work in New Zealand. And I've spoken at a number of events, and one of the things that I've decided is that I think it was Nike that coined the phrase, just do it. I think in health we've coined the phrase, let's talk about it. And I think we are really, really good at talking about it. And I think we are really, really ordinary at doing something about it. The question for you is, as a result of today, are you going to go away and say, I was at the forum today, we had some fantastic conversations? Or are you actually going to do something about it? Because one of the biggest issues we have in health for people who have a number of coexisting comorbidities is we have a system which is almost obsessed with subspecialisation, and a cohort of people coming through who just want somebody to look after them as a human being, as a person. And I think we've got a lot to do in that regard to get that right. The system is really disconnected. In New Zealand, one of the things that I think they do really, really well is I was going to say integrated care, but I hate the word, so connected care. I think they connect care really well within the community. So, and I'll give you an example of that. One of the DHBs that I'm working in has a coordinated care centre. I don't think it's called that, it's called something a little more fancy than that. But basically what it is a privately funded, it's funded by the DHB, it's not part of the provider arm, and it's more or less a care brokerage service. And primary care can ring this number, NGOs can ring this number, hospitals can ring this number, and they have real money that enables them to go out and subcontract straight away without worrying about all procurement and all these other rules around it to actually keep people in the home. And so if somebody's in hospital and requires a ramp so they can go home, that can be quite a challenge, and that can add a number of days of length of stay to the person, say, in hospital. In this system, they pick up the phone, they ring the number, they give the name of the patient, and I'm sure they have to fill in a form because we've all got to do that, and they immediately contract some providers to go out and build a ramp. It's done. And as a result of that, they've seen a significant decrease in the length of stay for people who are in hospital for non-clinical reasons. And I would wager that if we looked at any of our hospitals today, particularly for people in the older age group, you will find a number of people are still in hospital right now who have no clinical reason to be there. The other thing this group do is that they connect providers up. And there are incentives for people to keep people out of hospital and support them in the community. And again, as a result of that, people tend to work closer together. The relationships are stronger. And the one thing that drives it, actually there's a couple of things probably, but the one key thing that drives it is that the focus is on the patient. It's about the patient. It's not about the widget. It's not about ABF. By the way, I'm just going to say this because I can. I couldn't say it when I was chief executive, but I can now. ABF is the dumbest thing we ever did. I think what it did was give us the ability to understand our costs, and that's a really good thing. But I think it's outworn its welcome. Because when you buy activity, and that is the way you expand your health service, you are an activity. You are an activity. And all activity is good activity, because that's how we get money. So at some point, we need to think about how we actually buy care on an outcome basis. Now, that's a lot harder to do. But one of the things that the Alliance has an opportunity to do, and let me say, the Alliance, as far as we know, and if it's not true, well, we can pretend, but as far as we know, the Alliance is one of the few in Australia that's set up to actually try and bridge the gap between the feds and the state, where we actually look at care of the patient as the primary driver. So one of the things we're talking, and I think Nick Steele's talking later on this afternoon, one of the things we're talking to the department about is can we invest in some bundled care? And what that is saying if we had Commonwealth funding and we had state funding and we put it in a bucket called Switzerland, would we commission the services for those patients in a different way? And the answer is, of course we would. Absolutely we would. And we would probably find a lot of duplication that we could actually cut out and care which is truly seamless for the patient. Because I think what most patients want to know is how long am I going to be in hospital? When can I go home? Who's going to support me, waving the flag? Who's going to support me when I am home? So, because I've got to go, the one thing I want to leave you with is please use the opportunity of the Alliance. Don't think about, as an NGO, as a provider, how do I get more funding? Think about how do I collaborate with my partners to improve the quality of care. And I think if you do that, the funders are more likely to invest in you anyway because they are looking at different mechanisms which are far more patient-focused. So rather than let's talk about it, let's commit that as a result of this conversation today, we're going to do something about it. Thanks.
Thanks very much, Ken. Really appreciate that, and we look forward to working more with you in the Alliance, particularly with an outbased based contract in terms of improving care. Oh, there's that bloody phone again.
Excuse me, everyone. I was looking for Rhonda. Rhonda, it's Radar.
Hi, Karen. Hi, Radar.
Have you finished an ED yet? I was wondering if you have some capacity to outreach today.
Absolutely.
So, we need to visit Joan. She needs our help. We know this lady. She lives in a secure unit at a nursing home due to her advanced dementia. Dr. Kylie, her GP, advised that she has an advanced health directive and wishes to stay at home if possible. Remember last time we saw her? She was so distressed in hospital she needed a security special. Anyway, today Joan's quite unwell with an URTI, very agitated. Her family are rightly concerned and the nursing staff might need some support.
Absolutely. Couldn't agree more. Joan needs to remain at home being supported better.
Radar is on the move.
Phew. I'm pleased about that. Right. Now what we're going to do is introduce you a little bit to where the Health Alliance, the people participating in the Health Alliance are up to. Some of them you've already met, actually, like Elizabeth here, and she's ably assisted by Megan as well, who's sitting behind her in the radar green. And some of the issues that they've raised, and as Elizabeth has said, about the limited options in terms of outreach for RACFs and GPs, it's in terms of moving outside the walls of the institution. And we've also heard from Michelle, amongst other things, has been looking at just how hard it is to access, to get from the patient's point of view, accessing my aged care and assessment services and all those issues that actually become barriers to what should be sort of streamlined services. And we've had CIS, which is Community, Indigenous and Support Services, who today, where's Hayley? Hayley! And CIS also identified this big gap between my aged care and hospital, and we're very concerned about the fact that a lot of people end up in hospital because we underdo what's possible from community settings and respite and those sort of areas. And from the NGO sector, we have Desley? Yes. We actually have Shirley, but she couldn't come, but Desley's come along. And the community sector, from the discussions, are also concerned about the long waits that people have to actually access the care things, that they're not timely, and the limited transport support that people have to make realistic assessments. Of course, all these sectors had so much more to say. I'm just giving a very potted version. And then we had Jill from the residential aged care facilities. Jill. So a lot of discussion about residential aged care facilities, and Jill noted that often a lot of people are being referred to hospitals by default, not because it's the best place to be, but it becomes a default option, and exploring the issues of how it shouldn't be the default options, and particularly looking at the consistency with which important services like palliative care, their availability in that setting. And we had the Indigenous health services represented, and we've got Carmel. And among the issues facing Indigenous people was the issue of the fact we don't actually have a residential aged care facility specifically to meet the needs of Indigenous people, which understandably will be different from mainstream needs to express people's identity in that sense. And so as the Indigenous community is also experiencing ageing, there's a number of issues that we need to address in that space as well. And for the GPs, the long-suffering GPs, we had Dr. Vasi, Dr. Vasi, who has been very helpful in this whole process, and she introduced us to our folk from Kapera. And we had John Bennett over there. And from the GP point of view, they also identified the lack of being able to access the specialist services in out of hospital settings, and the issues of lack of incentives around providing comprehensive care both at RACFs and community settings. And last, they're probably on an emergency, was the ambulance service, but they were around the table as well because our colleague over here mentioned them, and they're really looking at broadening the options of when they get asked, so that the current sort of default option for them is they get rung and they take the person to ED. And so they're exploring what else can we do. Do they actually need to go to ED, or is there some other choice? So what we have there is right, as I was saying earlier, there's not one bit of this sector which doesn't have an innovative idea about how to make things better starting now. Not one bit. That we all have ideas of how to make this system better. And so we're in this process also. How do we then make that tangible and make that happen? And can I have the next slide? There's a slide up there, I think. Yeah. So the sort of overall consensus is that the whole system now is pushing people towards institutions. And the next slide, nothing wrong with an institution when you need one. When I get my aortic aneurysm, I want to be in one. But if I don't need one, a new aneurysm, I mean a new aorta, I'd prefer to be at home. And what we've got to do as a system is to think, how do we support older people to stay healthy well at home? And could I have the next slide? And we've talked about a future, picking up from what people around the table were saying about Indigenous aged care facilities, about increased palliative care in residential aged care facilities, improved GP continuity of care, yes. About specialist care outside of taking a community view, as not just a hospital view. I've talked about the ambulance services. It's getting a menu of options of things they could do when they get a call. And the community Indigenous services, including improving access to transition care and looking at how they much more facilitate their care in relationship with GPs and RACFs. And for the NGO and allied health sector, talking about timely access, flexibility and the precision of care picking up the points by Simon and Leonie earlier, is that one of the beauties of the NGO sector is to actually respond to that person's needs as opposed to the needs of the contract you might be after, or you might be engaged in. And Brisbane North, as we've discussed, looking about how to unpick these really complex problems about timely and coordinated assessment so that people aren't getting into barriers right at the get-go for their access to care. And in general practice, how do we support improve continuity of care, etc. So that's been and what's this all about? Making sure that we do meet patients' expectations and their hopes about receiving the care they need and feeling supported in the home environment. So that's where the group, that's doing a very short summary of some very in-depth thinking that has gone on around the room in the process so far. What we want to do now, unless we get interrupted. Oh, back at me.
Hi, Dr. Kylie. I'm calling to let you know that Radar, Dr. Bill Lucan and myself visited Joan today. We provided support to the family and nursing staff. They were a little bit, understandably, needed a bit of reassurance. We reassured them that home is the best place for Joan, and the nursing staff now feel very confident in caring for Joan during her illness. We've made some suggestions for delirium management, and we're certainly available if we can be any more provide any more support.
Thanks so much, Rhonda. I'll plan to visit Joan and check things out tomorrow, but I'll catch you at the GP forum next week. Radar's on target again.
That's great. These ads from our sponsors. Okay, what I'd like to invite you to do now is we're going to have a thing called a fishbowl, and I'm in the middle of the fishbowl right now. The idea of the fishbowl is that we invite some fish in, and Laurel, would you like to be the first fish? Just take a seat, Laurel, and make yourself comfortable there. I'm going to talk to Laurel to begin with, and then I'm going to invite the core group in, and they will continue the discussion with Laurel. And then after that, I'm going to invite you in. If you want to join the fishbowl, you just tap somebody on the shoulder or find an empty seat and come and sit down. What I'd ask is that people speak if they're part of the fishbowl, and that those of you on the outside observe. If you want to, as I say, if you want to say something, come into the ring. So that's it, and we have some chocolate fish for those that ignored the public health prevention advice and rising obesity and all the other good things. But Laurel, how are you?
I'm fine, thank you.
Thanks very much for coming, Laurel.
Thank you.
Could you tell the group a little bit about your journey so far?
Yes, I've been caring for my husband for many years, and for me to have him at home is the most important thing in my life. Last year, he suffers from Parkinson's, he has heart failure, he has a pleural effusion of the left lung, and he has neuropathy in his lower limbs. He was starting to gain a lot of fluid, so I went to our GP because I couldn't get him to go, and she wouldn't give me a script unless she saw him, which was understandable. Under the circumstances, he had to go into hospital. He was in hospital for 3 months. They took 20 kilos off him in a very short time, whereas that might not have happened if I had been able to treat him at home, if I had been able to get someone who could write the script at home. Now, our GP is excellent. That is not the issue, but it's not in her business practice to have home visits. So he spent 6 weeks at Prince Charles and 6 weeks at the transition care at Brighton campus. When he was discharged, August 4th, he had a wound in his feet that had cold and staph infection. But they sent him home, and they said, follow up with your GP. And again, how do I get him to the GP? It was all about wound care at this point, and antibiotics. So we got him under the care of the Chermside Community Podiatry team, and they taught me that you don't get the wound wet. Now, up until that point, at transition care, the wound was wet. It was never going to heal. The bone was exposed. They were worried about osteomyelitis. It got to the point that the vascular surgeon wanted to remove his toe and the big joint, and we refused because he would have immediately gone into a nursing home. With the Parkinson's, he has the tremors, and for him to be at home is the most important thing. For me to have him at home is the most important thing. With our home care provider, he was always a level 4, but the services were put into place last year. There's funds now available, a lot of unspent funds, that I would like to use to have someone come to the home. He hasn't seen a GP in 6 months. He's been under the care of the infectious disease consultant, but that's a specific specialty. So, in my perfect world...
Yes, in your perfect world. What? I'm sure you've thought about
I've
this.
thought about this a lot.
Yeah.
I would like to have a medical practitioner come periodically to review his medication, to see what he needs, what I need to help him better. He's very, very comfortable at home, and I want him to stay there. So, and the other thing that's important to me is that palliative care be only provided at home, so that the end of his life is spent with me in our home, so I can be with him, not somewhere. And that's nothing to do with nursing homes or anything like that. They provide a wonderful service, but where possible, he needs to be home.
Well, thanks very much Laura, for sharing that. And I need a bit of help to answer your questions.
Oh, yes.
So can I ask the core group to come and join me, if we could? And let's see where we go with this. Lisa, could you get Laurel some water, please? The fishbowl is dry. And we've got a fish... Oh, we found some water.
I've got some water, thanks.
So we've heard Laura's story. John, do you want to pick up the bat from a general practice perspective?
Yes. Yeah, look, it's a very difficult situation. You really want to be at home, yet you've tried and get some services there, and it's a difficult one. And I mean, just to reflect on a system sense, there are, over time, certainly fewer practitioners, practices as a system, willing to do house calls. And that makes your desires so much harder to achieve. And I sense a degree of frustration on behalf of you and your husband and what you'd like to do. And that's a difficulty across the system.
See, I think some of the medication could be reduced at this point. But it's not up to me to reduce it. I mean, the most important things are the furosemide, obviously, and the Effexor, and the Aricept, and the levodopa. But do we need all the others, considering what's going on?
Thanks, John. Liz, what's your thoughts about Laurel's situation?
Just so many points that you've raised resonate in terms of the challenges that we're trying to address in Metro North. It feels like, so your husband got hospitalised and was a long time in hospital and didn't go home potentially better than what he came into hospital. He went home with a different set of problems. And so our challenge is, how do we respond while he's at home, like you indicated? And how do we partner with primary care and other providers to actually respond at home in a rapid way and then have that longer term care that's coordinated? I think your story illustrates exactly what the system is delivering, which is not fit for purpose. And so things like radar will help us to respond quickly. The challenge will be then what you're describing in terms of that ongoing care at home. How do we deliver that? And where between the primary care sector and the hospital sector do we pick up that challenge, and how are we able to deliver that? In terms of the palliative care aspect, certainly in Metro North, we have we've worked together with the PHN in developing up a palliative care plan, and it's absolutely to try and address the issues that you've described. How do we have a connected system that is responsive and supports people to die at home? And so hopefully our plan over the next few years will be able to start to work towards delivering that. And if we can connect that up with the other aspects of radar, hopefully we'll have a comprehensive plan in partnership with other care providers to be able to respond to the needs in a more appropriate way.
Thanks, Liz. Michelle, one of the issues that Laura raised is the sort of flexibility issues. Do you have some thoughts about that? In other words, she has particular needs, but the system comes with a package, and if you're not in the package, that's right, Laura, you can't get those met.
Yeah, once again, unfortunately, a really good example of how hard it is to navigate the system. And, you've got medical management over here and community over there, and how do you find your way through? And for instance, thinking about your issue around medications, that you could actually be having an in-home medication review where a pharmacist will go out and sit down and go through all of your medications with you and then work with the GP around that. But once again, how do you know about this? So it's that issue around care coordination and support for people through what is difficult times, as well as a difficult system. Sorry, what was the other question, Don?
No, that was the question is what advice you had about that. Yeah.
Well, for me, it's the funds that are there,
with your
and
package.
to understand the level 4 care plan that goes through the home care providers is very confusing. Of how many hours, how it's budgeted, and then there's unspent funds, and what can those unspent funds be used on? And I would like to see them used more for someone to come and evaluate him. Could that be a part of the program? This is one of my ideas as part of the solution.
Yeah.
Is there some program that could be put in place?
And there may well be. As you've said, you would have a budget statement every month that would tell you how much money the government is giving to the provider, how much you contribute yourself, and what that money is spent on, so a breakdown. And it can be difficult to read those budget statements, although I think providers try to make them as simple as they can, and there are lots of complicating factors around payment from the government. But yes, there are guidelines around what that money can be spent on, but they're quite grey. And so if there are things that you think would be helpful to support you, then you are well within your rights to talk to your provider about what that might look like. For people who have difficulty in finding a consensus around that with their providers, they can use advocacy people like Advocacy and Disability Australia, ADA, where they will actually have someone come and help you, because sometimes people are concerned that they might lose their services, like they appreciate what they get already and don't want to create tension with the provider, so they're reluctant to have those conversations. But if you need help in that there are people who do that. And it is very much about working with your care provider to find what you need to support you and your partner best at home.
I think it's a very generous program. In reality, it's very generous now how they have it in place. But I think there could be better value. And I think that comes from the government to determine how to better utilise it, of what the needs are of the actual people that are out there utilising it.
Yeah, thanks. Jill, Laura mentioned the issue of palliative care, which is something you've been thinking about in the residential aged care sector as well, isn't it?
Yeah, palliative care, of course, is extremely important in our service delivery. Things like education are extremely important, that we have staff that are competent and able to cope with those sorts of areas. Also having access points back to places like Prince Charles Hospital and a GOAS team, the Geriatric Outreach Service. That's huge support that comes back into aged facilities, but the facilities still require staff that are competent and have leaders in those facilities that can lead that team. Also, GPs that are very supportive, local GPs that are very supportive as well. Very important that everybody's on the same planet, delivering the same good care that is required.
So, Jill, what needs to happen in the residential aged care facility sector for palliative care to be, readily available?
I would certainly envisage that all aged care facilities should be mandatory to have palliative care professional who works on site with supportive services outside, but extremely important that there be a person that's qualified on site with that management.
Some of the issues that Laurel's raised, NGOs and allied health are involved in. Would you like to comment at all?
Yeah, Laurel, just listening to your story and not knowing what you have in unspent funds, I'm just wondering if you could explore with your home care provider maybe some assistive technology that could link you in with your GP. So a bit of telehealth, where the GP might not be able to get there, but there might be opportunities for them to sort of consult that way. I think it's trying to think creatively within the limitations of the program and the funding. But I think, starting with just having the dialogue about what your needs are and being open with your home care provider and just trying to brainstorm what might be possible.
They do provide an RN that comes once a month to check him, and that gives me a lot of confidence. And I guess if she saw that there was a further problem that we needed to address, then we would go the next step, I guess.
Yeah.
But the RN coming to visit is very, very important.
That's good.
So looking further ahead, Carmel, we discussed a little bit, ageing for Indigenous people is an important issue as well. Do you want to comment a little bit about how you see the future in that for that community?
Yeah, I guess you mentioned specifically a residential aged care facility. I guess one of the reasons that people are really beginning to raise this as a bit of a priority in some ways is because I think there's been a really enormous change in community aged care service provision, specifically for Aboriginal and Torres Strait Islander people on the north side of Brisbane over the last probably 4 years particularly. So I think I work with an organisation called the Institute for Urban Indigenous Health that some years ago recognised that there were very few Aboriginal and Torres Strait Islander people who were accessing packaged care. And I guess the change really involved a fairly system-wide response. So the very short version of the story is that there are now around about 1,300 or 1,400 Aboriginal and Torres Strait Islander people on the north side of Brisbane accessing in-home aged care support services through an entity like the Institute, part of which also involved quite a specific strategy to actually grow the workforce to be able to respond. So I guess part of that was creating jobs for Aboriginal and Torres Strait Islander people to provide services for Aboriginal and Torres Strait Islander people in their homes. And definitely the system's not perfect. There's a long way to go, and I think many of the things that have been talked about today have specific relevance for Aboriginal and Torres Strait Islander people still in terms of hospital and community care in the home, and a need for all sorts of parts of those systems to continue to be improved and made specifically accessible for very vulnerable sections of the population. But I guess with access to an expanded range of community aged care services, the voice in the community really is growing in relation to I guess what happens when care in the home is no longer possible. And while we'll continue to do everything possible to make sure that's an option for people who need it for as long as possible. Where it's not, I guess, a residential aged care facility that really specifically meets the needs of the Aboriginal and Torres Strait Islander population is certainly something that people have flagged as a big priority. So one of our member organisations actually runs a really terrific residential aged care facility in Eagleby on the south side, Jimbalunga. It's on a beautiful block. It's a real community space, so families and kids and grandkids are welcome. Events are held there. It's really seen as home for the people who are there. And now a number of Aboriginal people from the north side travel to the south side when it comes time to have to move into a residential facility. So there's growing demand for people to be able to remain closer to home with a facility on the north side. And I think just to mention that the South East Queensland actually is the fastest growing region for Aboriginal and Torres Strait Islander people in the nation. It's expected that the population will double by the year 2031. So I think being able to keep up with that demand is going to be a really big priority.
Yeah, thanks, Carmel. Talking to the wider audience, this discussion you've just heard today very much mirrors the discussions that we've been having with the core group around frail older people. And I have the same feeling that I had there, that the solutions are all almost there, but they're not there. You can hear the solutions, like Michelle's able to unpick some of the issues about how Laurel's care could be better shaped. We've got Jill's aspiration. Everybody around us is describing how the system would improve. What I do want to hear from the panel is what's the one thing going forward you want to do to make that universal, so that the sort of difficulties, if we were to meet again in a year or in 2 years, the sort of system difficulties that we face now, we've at least made some progress. So interested in your thoughts going forward, panellists.
I think probably one of the greatest areas we can have is changing the way that we approach discharge. When people finish their clinical interventions or their clinical care, they're discharged. Discharged is kind of putting something to the left of side. I think we need to look at how we transition or transfer care, and sometimes that transfer of care might not be to another provider, it might be back to the family or the carer, and how we co-design that on discharge rather than it be a process and a system. So we've got some mindsets to change instead of just finishing the episode of care and then next time you come up we treat it as a new event and a new episode. We need to look across all of the care that you've been given in that year period and have a look at what's changed. Have you spent 200 days in hospital this year instead of 120 last year? And where could we have actually made a decision in those joined up episodes of care that enabled you to go home earlier with collaboration from packages and things? So we need to look at our information sets a little bit differently and challenge them and look at them from not from an activity point of view, an accounting point of view, but from a person's perspective of how much they have to utilise, and is that all necessary, or have we got waste in the system that it's making you stay longer or not allowing you to return home.
Thanks, Hayley. And we're now, just before Liz talks, we've got some empty chairs here, so anybody who wants to join the conversation, feel free, and you can take an empty chair or you can tap on somebody's shoulder and join the conversation.
Before I get kicked out of my seat, can I to expand on what Hayley said, I think when we think about the next expansion of radar is around being able to respond to patients in their own home as opposed to in residential facilities. And in particular, I'd like to look at the high-risk discharges, people who are very frail, people who have multiple problems, and people who have multiple medications. And I think perhaps that transition point we could actually focus on to support people in that transition period and then hand over to our GP colleagues once we've kind of transitioned through that.
Yeah, I just say thanks, Liz. But as a GP who, I'll just say, who does home visits and visits a residential aged facility, some more information, both of the type, what's happened to that individual patient for me, and also some upskilling, some knowledge around palliative care, around how you might deal with fluid overload, where you can ring somebody who actually knows what they're talking about and just give me that little bit of guidance that allows that person to stay where they really, really want to be, rather than make that awful journey sometimes to hospital where they just get so deconditioned and so unwell. It would be lovely. And hearing these things are really quite exciting, so I'm really, really, really keen to be involved.
Yeah, and I think working together with the hospital health service, GPs and providers help link the pieces together for the consumer. I think we have to make it easier for the consumer. Navigating with all the acronyms of MAC and RAS and ACAT is really quite confusing, and the flexibility of support that people want gets put into bundles, and when you need something from another bundle, you've got to start again in the process. So I think we have to have those conversations with government and the reform agenda to get people back in the centre of the debate and the discussion around what's best for them and how to make it work.
I think in aged care facilities there are a lot of things that are mandatory, as known as mandatory training. And unfortunately, palliative care is not one of those. We teach manual handling, we teach fire training, we teach chemical handling, but we don't teach palliative care as a mandatory. I think it needs to be mandatory, and it needs to be lobbied further towards the departments and be part of our accreditation processes to make sure that we are looking after people in aged care facilities well.
Anne, would you like to comment?
Oh, thank you. Listening to Laurel, and she mirrors quite a lot of my own concerns. So we have an older person. Laurel doesn't look particularly frail, but she's at an age when she could reasonably be frail, and we're all approaching that age. I cannot even begin to imagine how on earth she even began to negotiate this system, from the instant her husband was sick to every single decision she's had to make to find out where to begin. She's stuck at home with an extremely frail, sick man and nowhere to go at all. And somehow she's got to figure that out. Like, how does she even begin to make any sense of it? Why aren't we teaching people, providing education services when we're much younger on how to navigate these systems? We have massive education services out there for young parents to navigate what schools to send their kids to, what childcare centres and all this sort of stuff. We have massive systems to educate people where to put their superannuation money. The whole age health service thing is like the most phenomenal, unapproachable, completely reef-filled, dangerous nightmare, and we don't get any chance to learn about how to navigate it in advance until we're extremely needy and extremely frail. And it's just shocking, and I'm totally sympathy for you, Laurel.
Thanks, Anne. I can see some navigators across from me. Rhonda.
Thanks, Don. Laurel, I'm Rhonda. I'm a very, 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 very old nurse. And your story resonated across the room to me. I just want to acknowledge your story. What jumps off the page for me is, whilst we talk about care coordination, etc., education, sadly, the system recognises the hospital as the place where business occurs. And whilst we want to get out into the community, and we're working towards it and we're getting better, there's no doubt about it, and we've got lots of strategies in place. The thing that really you need and your husband needs to support you and work with your GP is a fabulous community palliative care specialist who I just happened to work with in Metro North. And I'm sure he's here as well in the back room, and I'm sure that he would be only too happy to have a chat with you in relation to planning for the future and putting, it's like you've got to have other services to dovetail. You've got wound management issues, you've got complex chronic disease issues, medication management. At Palliative Care Director, and his name's Dr. Bill Lucan, I'm sure he'd be only too happy to have a chat with you at the risk of dobbing him right in. Sorry, he's putting his hand in his face.
Thanks, Rhonda. Jeff, did you want to?
So my name's Jeff Rowland. I really came into the circle to get a fish, but I can seriously talk underwater. But, so there are so many things I need to talk about here. So the first thing is that originally I started my life in New South Wales, and as a geriatrician in Liverpool, worked with many different cultures, including Indigenous cultures and so on. But one of the things that we did in New South Wales, which really scared me when I came to Queensland, was we put a lot more funding into the aged care system, particularly around the aged care assessment teams. And Victoria puts even more in than New South Wales does, and New South Wales puts in about double what Queensland does, or what the Commonwealth does. So the teams down in New South Wales didn't just act as gatekeepers. What they did was manage people. They actually helped people manage through the system. They tried to keep people out of hospitals. They actually provided them with some rehabilitation. They provided them with links to the various community services that need to be done, and they advocated for people. And they provided a very close liaison with the hospital system, helping people to come out and helping people to go in when they needed to get in. Queensland doesn't do that. And I think that New South Wales and Victoria are actually defunding their aged care assessment teams too. And so we're going to a system where the aged care assessment teams are going back to where they were in the 60s, which is essentially just sort of signing checks to let people go into a nursing home and tell them what level of care they get, and that's about it. They're getting rid of the medical governance and they're becoming very socially oriented. And it's not about trying to enable people anymore, it's not about trying to make people better. And I think we need to go back to a system where we're trying to make people as well as possible and we're trying to help people through the system than what we currently do. And to do that, I think we need to convince the state government to throw in some money to the Commonwealth government so we're all working. The problem is there's too many buckets and everyone just wants to take care of their own bucket and doesn't want to help anybody else.
Okay, thanks, Jeff. Bernie, you've been waiting patiently.
That's right.
You're all good?
Yeah. My starting point is Don's, I think, third last slide up there, which actually was a definition of where you would like the final outcome to go. Can that be flashed up? It was about a final outcome, and it was really speaking about health. It's a definition of health. Goes back there. Yeah. I think that's what you're after. And what we haven't heard much about that this morning. But I've got an example out of our village that might help. But before I do that, I would just like to say one thing. I'm pretty old now, I'm 85, but I remember the time in the 70s when we developed community health centres. And there are physically still a number of those in Brisbane North. What are they used for these days, is the question. I raise that because I think there is a case for another physical focus that people could use or be associated with that isn't a hospital. And that's one point. The second point out of that era was that there used to be a definition of quality life years. They were called QALYs. This morning in Stefan's presentation, we didn't hear anything about QALYs. What we heard about was DALYs. And I hope everyone knows what DALYs are, but they're disability adjusted life years. And that's exactly what's been going on for the most of this session. We've been talking about disability adjusted life years. But there is, or there ought to be, the other side, which is the QALYs, quality adjusted life years. And it used to be measured by the number of years that you were regarded as being healthy and you were in quality life years. I'd like to throw that in as a possibility that we ought to reinvent. I mean, it's bring it back to life, I suppose.
Thanks very much,
Now,
Bernie.
If there's time, is there time just to tell you one thing that's...
We're a bit near here.
All right. Can I just take 1 minute? Because I think a lot of people will respond to this. In our village, we've got 254 independent living units. Now, you can just think of those as being all clustered, or you can think about them as suburban homes. But one way or another, that's what we're talking about. Now, one lady living in a unit in the last 2 weeks became isolated because her daughter, who was a usual contact, was away from Brisbane. A granddaughter was called by this person. The person was in distress. She was vomiting, diarrhoea, and was dehydrated. She was inside her unit. It was locked, and she didn't wear her contact, which would have taken her to Tunstall, who would have organised a community, a response from the appropriate community. What happened was that the granddaughter called an ambulance. The ambulance couldn't get in. They called the fire service, who broke in. Then they decided they needed a second ambulance. So we ended up with 2 ambulances and a fire engine at a 1 unit in a retirement village, and it all could have been avoided if she hadn't got into a dehydrated state in the first place. It's just a timely example of how you can have all that resources on one side, or if you'd done the right thing up front, it wouldn't have happened.
Yeah, thanks very much, Bernie. And I'll just take your idea. I think we should have ability-adjusted life years rather than disability-adjusted life years. I think that's a good idea. This conversation isn't going to end, literally and figuratively. So, Eric, did you just want to have a last word?
Yes, it's a very quick one. When a couple are living independently at home quite well and suddenly need home help, it happened to us. It took us 7 weeks to be assessed and get home help to come and arrive, by which time I was absolutely exhausted and worn out, carrying a double load and looking at the extra load, looking after my wife as well. So we need, in some way, to speed up that home assessment and getting support. Thank you.
Oh, thanks very much, Eric. And we had
I will be very quick, I promise.
Just one last
I wanted
word.
to end on a bit of a positive note then in that case, because I'm a nurse navigator, so newly introduced from Queensland Health 18 months ago, and that is exactly our role, is about that link between the hospital. My first question would be around why, Laurel, your husband had to spend 6 weeks in hospital in the first place, so that's where I start. The connection in the hospital, and then I help with the links out into the community. And it is about, so there are some, there's some really good pockets of work being done, and we need to be on that positive sort of ending that we really are trying to address all of those gaps. And I have the ability to work both within the hospital and within the community, so I will go and visit you in home. I will help you with your ACAT assessment, and there's a lot of navigators now in the community as well, and that is their role. And I think we've said the word navigation quite a bit even before I got here. So that is the intention of this role, and so there is some really good work being done.
Yeah, thanks very much. These pieces of paper, a lot of you have been sitting there and haven't had the chance to be in the Fishbowl. You're allowed a chocolate fish if you write on these pieces of paper. If you've got any messages, thoughts, contributions, please put them there and we will share them. There's also some cameras over there if you want to take a photo. I'm particularly interested in cameras. Yep, there was... Lisa, do you want to demonstrate?
Oh, no. I was just...
Yeah, you're gonna, no, we're all good.
Oh.
Just distribute the cameras, that's the main thing.
Distribute the cameras, take the photos, hang them up on the washing line. The idea is to collaborate.
Yeah, so we're interested in...
Join up, like we just heard Jodie's going to help Laurel to get photos together and hangs it up on the washing line and says what the initiative is that we're going to work towards.
So, just to conclude, we started exploring the issue of age with Simon and Leonie, which is really good, and it's sort of those deep structural things are so important. And then we've sort of covered the ground in terms of the core group and its members and its discussion, and then invited you all in. But it's all a work in progress. And what we want to do is to invite you to continue this process. I really like the way people responded both to Laurel's personal situation, but also it's the broader system things that we need to work on at the same time. And to do that, we actually have to work together because there's deep structural problems. As Jeff said, we even sometimes go backwards rather than forwards in our approach to care. So thank you all very much. Please use the cameras and the cards. And the Health Alliance now has a website, so if you're interested in staying in touch or want to engage more, and please stay in touch with the core group leaders from your part of the sector. They've played a critical role and will continue to play a critical role in going forward. So thank you very much, and a very special thanks to Laurel who started us off in the Fishbowl. Thank you.